Dear Chairman, dear colleagues, good morning. My name is Dr. Katerina Kulyk from the Kepler University Clinic of Linz, Austria, and today I will show you our findings on persistent primitive trigeminal artery investigated with ultrasound. First of all, what is a PPTA? Well, we know that in the early phases of the embryonal development, the vertebral arteries develop much later compared to the carotids. And therefore, the blood supply to the primitive basilar artery, which is actually more like a net of fine vessels, as you see here, is guaranteed by these four carotidobasilar connections, the biggest and the most rostral one of them being the PTA. This vessel then regress in a caudorostral manner, but for some unclear reasons, PTA can persist into the adult stage in about 1% of cases. There are many ways of classifying it. This is, for example, a surgical classification where we can see how the PPTA connects the internal carotid artery and the basilar, either in a Petrus variant where it comes from the lateral side of the internal carotid artery and has close connections to the sixth and the fifth cranial nerve, or the medial or sphenoid variant. Or we can have an anatomical classification called Salzmann-Wien, which is more based on the configuration of the posterior circulation. PPTA has been linked in descriptive studies to aneurysmatic formations, arteriovenous malformations, or trigeminal neuralgia, but there has been no conclusive data on its clinical significance so far. So, and most of all, nobody has ever evaluated its hemodynamic effects on the intracranial circulation. And that's what we decided to do using ultrasound. We revised all of the MRAs that were performed at our center between December 2013 and 2017, and we identified 6 patients with PPTA, which were then invited for extensive ultrasound evaluation, and in the end, we got 4 patients in our final cohort. So here they are. The first one is a 79-year-old female patient. She has recurrent episodes of vertigo and nausea that she has been having for more than 20 years, more or less once a month. She also tells us about recurrent tinnitus in her right ear. She has been evaluating this episode several times, and once she has also been told that she has had a TIA, but she couldn't say much more about it. In 2016, she came in our clinic for acute evaluation for another one of these episodes, where she also showed signs of cerebellar dysfunction on both sides. She had a bilateral gaze of nystagmus, a bilateral ataxia of her limbs, and a positive Romberg sign. In the acute MRI, there was no ischemic lesion, but what we saw was in fact PPTA, which was connecting the right internal carotid arteries with the basilar. As you can see it here. Also, interestingly, she had a very hypoplasic vertebrobasilar system, especially in the proximal part. On the ultrasound, the left vertebral artery showed a hypoplasic diameter with no flow that could be detected. On the right side, the vessel was hypoplasic as well, and there was a flow that was not even close to being compensatory. Intracranially, the anterior circulation was okay. We could identify the PPTA that was, you can see it here in this image, which shows us an installation from a transtemporal left window in a coronal plane. And we can see the P1 on both sides and the PTA. In the transforaminal window, it was also interesting to see that the V4 on the left side, where we detected no flow extracranially, was retrograde, and the V4 on the right side was orthograde. Also, the basilar artery in this proximal part was actually retrograde, so we can assume that the V4 on the left side and the proximal basilar were at least in some degree fed by this by the activated PPTA. Also, interestingly, the breath holding index, which we tested on the middle cerebral artery, was very asymmetric, with the right side, which is the side that feeds blood to the PPTA, having a very pathologic value. And here again we can see in better detail the PTA, the P1 on the left side, the P1 on the right side, and a comparison with the MRA. Our second patient was a 50-year-old male. He had a similar history of more than 10 years of episodes of acute vertigo. Once in 2013, he came to our clinic for an acute evaluation during one of these episodes, which was very severe, and also he had at that time a right-sided dysmetria of the limbs. In the MRI, we saw a hypoperfusion in the right pica territory, and again, this patient had, of course, a PPTA which was connecting the right carotid artery with the distal part of the basilar, and he had a very hypoplastic vertebrobasilar circulation in its proximal part. In this case, there was no reverted flow transcranially in the transforaminal window, so we can postulate that in this case, the amount of blood which was going from the PPTA to the proximal part of the vertebrobasilar circulation was not as much as the patient before, and this could also maybe explain why this patient also had a hypoperfusion. As in the previous patient, here we also had a very impaired breath holding index vasomotor activity on distal to the carotid, which was feeding the PPTA, so on the right side. Our third patient was an 88-year-old male. He had his PPTA discovered incidentally while he did MRA and MRI for a therapy-resistant bout of hiccups. Actually, after Illes operation, there were no diffusion alterations, and the MRA showed us a PPTA this time connecting the left carotid artery. There was no pathology, no symmetry of the external intracranial circulation, no evidence of vertebrobasilar hypoplasia proximal to the trigeminal, to the PPTA, which was also not really visible in the TCCD, maybe because it was this time a little bit more proximal, or maybe we can postulate that it was not so activated, not so functionally activated as the two patients before. And the vasomotor activity was symmetrical and physiological in spite of his old age on both sides, left and right. And the last patient was a 40-year-old female, which came to our clinic because of a new onset of untriggered generalized tonic-clonic seizures. She also reported of having a severe hearing loss in the left ear since 1 year, so severe that she needed an acoustic implant at the age of 40. We performed an MRI which showed no ischemia and no focal cortical dysplasia, and a PPTA on the left side. So actually this patient had a PPTA which was quite proximal in the middle of the cerebral artery connecting to the left ICA, which is on the side of her hearing loss, which leaves this now actually open to speculations. She on the connection of these two events. She had no asymmetry of her vessels whatsoever, no vertebrobasilar hypoplasia, and the vasomotor activity was symmetrical and normal. So in the end, what we can say is that PPTA has been considered a meaningless finding so far, but actually it can sometimes become fundamental for the perfusion of the brainstem, especially in its proximal part, and especially in the context of a severe vertebrobasilar hypoplasia. It can be so relevant that it can, in fact, impair vasomotor activity on the same side. And I think, once again, this data show us how important a thorough intracranial evaluation can be in many patients, and especially in patients with an unclear history of vertigo. Thank you very much for listening, and enjoy the rest of the conference.